trends. So let me ask you, just kind of get started, and then we're going to talk about, what we see as trends, excuse me, things that work, things that don't necessarily work. And then we have some questions that some of my patients sent in as well too. But
sure,
before we get started, tell us a little bit about how you got started. I mean, why did you got interested in hair restoration? You've got a great head of hair. I mean, so what interested you?
So basically, I did my fellowship in facial plastic surgery and trained to do hair restoration. At the time, I thought it was quite boring and just like making holes, and it really didn't excite me. But I got back and met this woman, Amina Vance, who's been with me as my hair coordinator now for 20 years. And she sat down with me and was talking to me about creativity. And I said, what is creativity? And I started to see, I can actually design female hairlines, eyebrows, etc. And that creativity is what has sparked my passion in teaching hair. I run a hair course now for about 15 years, and I just love teaching. I love the design, and that's really why I love hair.
Right. No, I think I think what you just mentioned, though, I think is a very valid point that, it's not just about creating a hairline. It's about creating an artistic hairline. It's about creating something that looks, in our industry, natural has become really kind of the key buzzword. But I think it's important because, I always tell my patients a monkey can do your procedure, but chances are it's going to look like a monkey did your procedure. So when you have someone that's, has a skilled aesthetic eye like you have, and that, can actually look at, your male clients, your female clients, and, and all the variations in between in terms of looks, and also ethnic considerations. There's a lot of things to keep in mind. It's not just about connecting the dots, and it's not just about, planting hair. It's really about having a fastidious and thoughtful conversation with a patient in terms of, what to do, what they can achieve. And that being said, when do you recommend patients getting a hair transplant, or kind of talk a little bit about the process?
I think a lot of people ask about inquiring about the family history. I actually don't even care too much about that, because I look at a patient, I can already tell how they're going to age. Now, I always say it's like stocks in a way, maybe not during the COVID crisis, but in general, the longer the history of a stock, the better I can make a determination. So the younger the patient, the higher the risk, especially if they're beginning to bald. I have to predict, I have to see what it's a supply and demand issue. If they've got a huge demand and very little supply, and they're young, and I know that supply is going to get worse, and if I do surgeries, and the demand is going to get more pressing, I've got to have that ability to see in the future who has enough supply to outweigh the ongoing demand issues. So age is a huge part. If they are already an advanced Norwood 6'7", and they're, here's a worse example, Norwood 6'7", 20-year-old, impossible.
Right.
I would say in general, anyone under 30 is risky, but I still do operate on some individuals under 30, but it's very selective. And unless they're female, I mean, if they're female, even though women do, 30% of women over the age of 30 lose hair, but they don't go bald like men. So I don't feel as a problem like a female hairline lowering at 20, etc. But age is one of those big criteria, and their degree of loss as a criterion for of doing a transplant.
Do you ever worry, when I see the young patient, just like you mentioned, the patient that's like, 21 years old, is starting to have a lot of frontal recession. Do you ever worry about the hair islands? You plant it in front, that hair stays, and then all of a sudden now you have recession from the back, and you end up with, that kind of, I don't know what we call it, kind of the monk's cap,
That is absolutely the problem. And no offense to the young patients out there, but I had a 27-year-old gentleman. At the time I was 42, I'm 51 now, but I remember very clearly, he said to me, Dr. Lam, please give me a hairline like this, because I don't care what I'll look like at 35 or 40. And obviously, people don't have the ability to predict how they're going to feel in 10 years. For me, I feel maybe 60 is older because I'm not 60. My mom, who's 80, thinks 80 is super young. So I have to protect the patient for what they're going to have. And so that's the other problem, is that not only is there a risk of that progressing and getting bad, but the patients are highly unrealistic oftentimes about what they want. You know, so that's a very good point. It's the most important point of, if we forget everything we talk about cool new fancy toys and new things going on with the industry, safety is the most important thing I could communicate during this talk.
Totally agree. Totally agree.
Yeah.
What do you, you know, there's a lot of, we've kind of jumped into the kind of the end of, you know, the process, the actual hair restoration. But if you have someone, when I talk to patients, you know, there's a whole continuum. You know, you start out, not every patient starts out with a full blown, you know, neograft or artist or whatever technique you want to use. You
Right.
know, sometimes we'll use supplements. You know,
Yeah.
medically, we're looking at reasons for it. And, you know, as I'll let you kind of talk about the differences, because there's very
Sure.
distinct differences between, you know, in terms of gender differences, why men lose hair, there tends to be, you know, one reason, and why women lose hair, it's a different. And there's a lot of medical factors that could play into that, that if they're not, you know, if they're not evaluated, then you're really not kind of figuring out the root cause. So
Yeah.
you want to speak to that a little bit, kind of like
Yeah.
how you cancel that first patient though.
So I think the best way to do is divide it by gender. So for men, I assume that is male pattern baldness. If I'm seeing a male pattern baldness, I'm not going to do too much investigation with hormones, et cetera. But for example, I saw a gentleman that was a virtual consultation during the COVID time, 61 years old, thinning on the front. And for someone that's not really trained in hair, they would say he needs some propecia. Maybe he gets a good transplant. Immediately, because I've been doing this for so long, I could see that it didn't look quite right. And I pressed the issue. And I said, do you have burning sensation? And it turns out he was using sunscreens, not to get into that topic, but there's certain sunscreens that can cause a permanent hair loss here called FFA, frontal fibrosing alopecia. And so I dive deep in that, and he's not a candidate for surgery. But so barring those exceptions for men, it's basically male pattern baldness until proven otherwise. My biggest thing that I've been doing that's been helpful for men that are afraid of permanent sexual side effects, et cetera, the things, the scary stuff you see online with oral propecia, which I think is incredibly rare, but of course no one wants to hear that, is I've been doing topical finasteride and minoxidil combination. That's been really my mainstay. But laser technology works. Nutrafol, nutritional supplements definitely work. To me, those are sort of my trifecta of things that I look at for men, with the topical finasteride being sort of the gold standard. For women, topical, I use a compounded minoxidil. There's been some evidence that there's been an inflammatory component for women. So a compounded minoxidil can help. Lasers can actually be a little more efficacious in women, and nutritional supplementation. But the main thing is we have to look at women and go back and say, okay, well, that's great, we're treating it, but oftentimes we have to look at, do they have heavy menses that need iron replacement? Do they have hormonal imbalances, especially if they start getting into menopause? Hypothyroidism. I do a little bit more investigative work, and I usually work with like an endocrinologist or a family doctor. I give them a list of things. It's on my website, of things, the metabolic things I recommend for women to get, hairtx.com. So that's a quick summary.
PRP, talk a little bit about that as well too. That's something that I personally have had, I don't know, probably half a dozen, sessions with that. And I've also combined that as well ttoo with ACell. And you and I have had that conversation about, about ACell. I mean, I personally, my bias is I think turbocharging, and that's how I describe it to patients, turbocharging your PRP with other things than just PRP, I really think gives you more bang for the buck. What are you using right now? Are you still using ACell, or are you adding
in my hands, I have not found PRP to be as consistently beneficial as a standalone treatment. It's probably because I'm not doing it as many sessions. A lot of people doing a lot of sessions, and I think you can get some benefit from that. Where I see it right now, I use PRP, ACell, ATP, and hypothermosol. That four cocktails for almost a decade now, one of them a decade. And I found those to be incredibly good for graft survival and growth. But as a standalone PRP, I don't always get the results. Some of the new things that people are looking at right now is exosome therapy. I'm not too certain if that is all that in a bag of chips, because some people have gotten some results, but I haven't always seen the consistency. There's so many brands out there. A lot of my patients have tried it from other places that are quite reputable, and they were telling me I didn't quite see it. So I'm not. It's that holy grail is still the holy grail,
Right. What do you think about? I mean, we've been looking at nano fat injections. I mean, what are your thoughts on that? Because fat's been very restorative in a lot of things. What about hair?
So, that's an interesting question. I'm glad I can talk about this one article. As it was, I reviewed it as a reviewer for one of the journals, and it was embargoed until it was just published. So now I can talk about it. It was a great article, very well controlled, evaluated patients over a period of a year, looking at more sliced fat. I don't know to what extent it was totally nano fat or not. And they did find statistically significant improvements in hair growth. However, it wasn't sustainable past 6 months. So my concern is when you're looking at a higher donor morbidity, in other words, just taking out fat repeatedly. I mean, unless you eat, fast food every day, you're not going to have unlimited supply of fat. And so my concern is like PRP, you can always draw more blood. Whereas if you're really going to get in this study about 6 months of results, can you really be doing lipo harvesting every 6 months on someone for 20 years? I don't know. I think the morbidity exceeds the benefit. And I don't know how consistent the results are with a single therapy.
Right. Now you mentioned, I'm going to go back to, you mentioned lasers. Talk a little bit about that. I mean, I think,
Yeah.
I'm thinking Austin Powers here, and, these
That's
big, huge
exactly.
lasers. What
The
kind of
shark
lasers are you
costs
using?
extra if you get the shark. But no, basically, it's been around since 1968. I mean, a Hungarian scientist found out that lasers can actually grow hair as a side derivative benefit. But about 10 years ago, people are getting those large ones you have to drive into the office, and they just simply don't work. Since about 2014, they've been really refining this technology, and they've been multi-institutional, peer-reviewed, qualitative analyses, really well-controlled studies that have shown qualitative improvements in hair counts. And I have seen it. I've seen it as a standalone therapy to improve hair. Essentially, I don't like to talk about brands, but I would say that most of the lasers that have the right fluence, a lot of people are now buying really El Cheapo ones out there that I just don't think have the right, they're not even real lasers. It's a diode laser between about 650 to 700 nanometers, and it stimulates cyclic AMP. Sorry to be talking technical, but it's the dermopapillar base of the hair follicle. So there's two stem cell zones. It's the bottom one, and that's it's causing that turnover to create a growth cycle. And you wear it for about 20 minutes 3 times a week, or 30 minutes 3 times a week. You don't want to overstimulate the scalp.
So you're talking about the caps, right?
Yeah, exactly.
Yeah.
Yeah.
So, I mean, yeah, I mean, so for those of you guys watching, I mean, it's not like you actually even go into the office. There are these little caps that you wear, and you basically just, what is it like for like 20 minutes or so? 20, 30
Yeah,
minutes?
20 to 30 minutes. Some people argue that they can do 6 minute intervals. I still believe that 20 30 minutes is more ideal, no matter what the manufacturer says. That's my feeling.
I'd leave it on longer because they're cool. They're cool
Yeah.
looking. So I've got a couple questions I'm going
Yeah,
to that our viewers actually asked.
sure.
So after a hair transplant,
Yeah.
when will I see my hair grow? So I mean, do they walk out with like a full head of hair, or what's the process?
So, so I'll give you a quick history. Before I started adding PRP, cell, all those things, I was seeing on average around, and FUE, keep in mind, has evolved significantly over the last decade. So the grafts are much less fragile than they were 10 years ago. So I was seeing FUE growth much longer. It took me much longer to grow than the strip procedure, on the order of like 9 to 12 months. Then I started seeing it go to 6 to 9 months. And then I added PRP cell about 10 years ago, and for all my procedures, but really for FUE, I started seeing take off about 5 years ago, dropping down to about 5 to 6 months. And in 2013-14, I also added hypothermosol and ATP, which I can speak forever on. And I've been seeing these grafts progressively grow faster and faster. I sometimes see growth as early as 3 to 4 months. To get to the 3 month time, you have to use all these technologies for it to grow, and not everyone gets it. It's that 10% where they don't go through the effluvium. Their hairs don't actually even shed at 2 weeks. They just continue to grow. But it's a very small minority. So the answer to the question, without getting too technical, I would say 5 to 6 months with some decent growth. And if you're using some regenerative techniques like ACell or PRP with it, if not, probably 6 to 9 months, and full expression probably 12 to 18 months.
The next question was basically how many sessions will I need, which I know is really hard to say because it's going to really vary. Yeah. But on average, I mean, do you see, obviously age-wise and degree of hair loss, do you have a lot of patients that have one and done and they just say, you know, we're just going to maintain it now with PRP, with minoxidil / Propecia,
Right.
you know, a Nutrafol, or kind of what's the course? What can someone expect in terms of
I
like
think
long term?
the right. That's there's so many factors. One is realistic expectations. People that have unrealistic expectations may want to have 3 sessions. But what I always try to tell my patients is, don't go crazy with surgery, because I may stage it over the next 10 years to say, hey,
Hmm.
I'm going to run out of hair. If I keep trying to stick hair up there, it won't be right. Or if I make too much density in the front, it doesn't fit a norwood pattern. That's a problem.
Right.
So, and
Right.
also depends on how wide an area, as you're alluding to. If I'm doing front to back with a crown, the crown may still have some see-through. And I tell my patients, if I don't think I have enough to do the crown decently, we're either not going to do it, or we're going to do it in a way that would age well for you, and not
Hmm.
push me to the limit of what I can. Because if I run out of all donor hair, I have nothing in the bank. And I don't mean money. I'm talking about your donor bank for future loss. So that's a hard one. But the one thing that I'll tell you is very different from 20 years ago, or even 30 years ago. I've been practicing close to 20 years, but they used to do these transplants where it looked totally crazy and you just had to get that second session for a result. Today, I think people are trying to get a great result with one. And then if you need more, it's only to further enhance what it is. But you could walk out with one and be done, I hope, for a while, minus
Right.
the progression issue.
Well, I think, I don't know if I told you this, but I had last Valentine's Day was a Valentine's Day gift to myself, and
Yeah.
I'll kind of put my hair down, so you can, so
Yeah,
you
it
can
looks
see my
great.
hairline.
Yeah.
So, I mean, I think, and I'm not saying this in a boastful way, but
Right.
I had one because several reasons. One, I was losing my hair. I'm 53 years old, and I'm like,
Yeah.
just like you said about your mom, 80 years old, she
Yeah.
feels young. I feel
Right.
incredibly young. I don't want to lose
Right.
my hair.
Sure.
So my hairline went way back here. So
Yeah.
they really focused on the front, but I
Right.
think gave a natural result
Looks
and was
good.
neat. Thank you. And what's great is I can tell patients when they come in, I can show them the back, and I had the
Yeah.
FUE, the follicular unit
Hmm.
extraction.
Right.
You literally, I'll lift my hair up,
Yeah.
and it's usually pretty short. You can't see the scars. I mean,
Yeah,
it's
that's good.
really, really, really nice. Um, will I be asleep for the procedure? Are you doing these? I'm assuming you're doing most of these in your office, or you have an office
So
procedure room
for
or OR.
Yeah, and that's a tough one, because I have a accredited facility. I give patients some sedation. Great examples. I was doing FUE case on a gentleman, very fidgety, on Monday, and I can't imagine doing that case with him not being under some sedation. A little bit of Demerol, just something just
Mm-hmm.
to get him knocked out and feel more comfortable. A little Benadryl IV, because he was just really agitated. I couldn't do the harvest. So with after that, he was totally chilled and totally fine. So everyone is different. I do what's called level 2 conscious sedation. So it's going to depend on your surgeon and his facility and what he feels comfortable doing. You know.
Right. I mean, I actually, when I had mine done, I mean, I had, what did I do? I took a little bit of Valium, and I think I took a Percocet.
Yeah.
My staff laughed at me because I guess I said some goofy things, but the hardest part for me, it was actually not the pain. I mean, for those of you watching it, we do basically a ring block.
Yeah.
We do local and so forth. So you're putting a lot of this numbing in, and once you get over the initial pinches, it really doesn't hurt. I think the hardest thing for me, at least, was because I'm always so active. It was
Right.
hard sitting still in one position for a while. I was bored.
Yeah.
I mean,
Right.
so
Right.
but it's not. But pain wise, my goodness, I mean, I would, even after the procedure, I think I took pain
Yeah.
medication for a day, and then
Right.
my head was kind of swollen and so forth, and I just sent all these goofy pictures to my friends, putting little divots in my face, and but otherwise it was really easy.
Hilarious.
Um,
Yeah.
are there any visible scars? Talk a little bit about, if you would, the strip versus FUE, just so everyone kind of knows
Yeah.
the difference, because I think that's important.
Right. So, there's no scarless procedure. I think that's the most important take home. You can't shave your head afterwards. A colleague of mine actually did a side-by-side comparison of strip versus FUE scars, and in good hands and good patients, they're almost indistinguishable. But there's a psychological negativity with having a strip procedure,
Mm-hmm.
because there's an incision. I still do a very huge percentage of strips. I do 2 or 3 FUEs a week, and sometimes 2 strip back, or I'll switch off one or the other. And for me, the strip works in several circumstances. Women I love the strip. And the reason for it is they wear their hair long. They don't have to shave anything. Even if you do a non-shave, that's really a lot of labor. And also, if you do a lot of FUE on the back, harvest quite a bit of hair, you can actually sometimes feel it being a little bit thinner. And in women, they don't want to even feel that. Plus, women lose a lot of hair in their temple zone. So taking it from the very center works the best. When I have a gentleman who's extensively bald, I mean, I need thousands and thousands, 4,000 grafts going from front to back. I still prefer the strip if that person wears their hair longer. I mean, I most likely could get it to the point where they wear their hair short and still not see anything. But there's the strip allows me to get a much larger number of grafts that I feel I have still preservation of donor hair for future use than the FUE does. And I can stay away from the crown, because when you start to harvest a large FUE session, you start to extend beyond what Unger called the safe donor area. You've got to go toward the limits of what's possible. So small, medium cases up to 2,000 grafts, I think FUE and FUT work very similarly for men. When I start pushing those limits of larger sessions and wider zones where I have to cover large extensive crowns, I usually prefer still the strip. So those are my biases. Of course, you're going to talk to 10 other surgeons; they'll have different biases. You know?
Yeah, there's a lot of right. 'Cause I've talked to other guys about it. I mean, like you said, you know your stuff. It's so funny. I mean, it's so much more of an art than a science.
Yeah.
Because you have people that say, well, I've always done it this way, or it's worked for me, what have you. A lot of variations. Now, one question I would say is, when we're talking about doing multiple sessions, how do you stage those? Do you do one treatment and you say, okay, you can plan on probably 2 or 3 sessions based upon the degree of hair loss and the availability of donor site? If so, you do your first treatment. How long after then? How long do you wait to do the second?
So, yeah, I would basically say I always love to wait a year if I humanly can, because, unless I'm doing one area and then a different area, if I'm doing the same area, a year later allow it to grow in so that you can make a decision whether you even need it. And especially if on medical therapy, you could wait to see everything grow. And also, if you're a younger gentleman, for example, and you really want even more density, well, as I told you, the biggest thing is I want to make sure I have enough for future hair loss, and I can't just go in there and transplant willy-nilly. For strip procedures, I would say I can go as early as 6 months. But again, I want that incision to heal well and really have have a tremendous laxity. So I would definitely, in either case, I would love to wait a year at least, if possible.
That makes sense. And that's actually what I always tell my patients. I mean, you really have to give the hair enough time to actually declare itself, because sometimes you're actually surprised. Sometimes you look and you say, what, this actually looks better than I thought, or, vice versa. But just jumping into it and being really over aggressive, I don't think is really the best thing. How long will it take for someone to recover from the procedure? And obviously, talk to FUE versus strip. You've got someone that say, is in front of a lot of people, an attorney, for example, is in court a lot.
Right.
How long do you tell he or she to take off work?
So again, every surgeon is different. So what I find, I break it down into pain, swelling, bruising, and scabbing. So pain-wise, FUE is almost nil. It's very, very minimal pain at all. Swelling, I use a little bit of a steroid infusion that this guy, Abbasi, discovered out of Iran. And I only get swelling around the eyes in about 15% of my patients. But when that swelling is there, it's very distorting. And that occurs for both FUE and strip procedures. I tell them wear sunglasses. I have seen one patient last 8 days, but the vast majority about 5 days, and only in, again, 15%. Bruising, very minimal to none. Scabbing for both is the issue. Is you can see scabs. If they're very bald, you can see scabs, and that you can rub away in 7 days. In the donor area for FUE, you can see scabs back there, and at a week, the scabs are gone and the hairs are grown in enough you don't see it. From a strip procedure, you don't even see the incision to begin with because the hair is covering it. And there's a little more discomfort, but I do it so well with tumescence that my patients maybe have 1 tick more discomfort than FUE, but not much more. And then the scabs and the swelling are the same for both, So bottom line, I would say about 7 days. The only restriction I have with the strip procedure more is I just don't want as much traumatic injury to the back, whereas with FUE, I'm not as worried because there's not an incision,
So, both you and I probably did some training on hair transplantation during our residencies. I mean, and I have to say, I don't do as many as you do, certainly, but what I've seen though is in the last 10 years, it has changed dramatically. I mean, what we're doing technically, I
Oh,
mean, in terms of survival, in terms of the look, I mean, I think you'd agree it's night and day. I mean, you look at the old way of doing hair transplantation. You've got those cornrows that go
yeah.
straight back. You look like you
Oh, yeah.
drive a tractor through them. They look
Sure.
horrible, and I've
I know.
fixed, and I'm sure you fixed plenty of those. Those are really
Yes.
not a good look. But now, like I said, one of the reasons I got it done is so people could look and say, oh, that I actually wouldn't have guessed. It looks very natural.
Right.
Where do you see this in the next couple of years? What are going to be the next progressions as we get better and better at this?
I think that a lot of the non-surgical stuff is hopefully going to continue to advance, from nutritional supplementation to, as I was saying, exosome therapies. So from the non-surgical side, there's a lot of technology there. Of course, the holy grail is the gene technology, which is hair cloning generically. But we also, or bioengineering, which would give us unlimited donor hair. And that's already been shown in animals. So if that happens, we're all good. We don't need FUE, we don't need strip, we don't need anything. We just have unlimited
Right.
hair. From a technological standpoint, the biggest advent in the last probably 3 years is using what was called hybrid devices, which are basically sharp outside, they look like a trumpet. There's a blunt inside, a sharp outside, which allows you the best of both worlds. They can harvest without the transection rate of older technologies of FUE devices. So that has been huge. And I think there's going to be ongoing improvement. Just like I've written the only textbook in the world on FUE, came out in 2015. I'm currently writing a double volume book, 65 chapters, coming out next year. That's 5-year time difference between the two books. And that's how much the landscape of just FUE or hair transplant has changed. So yes, those are the big things, I think.
Crazy question. When are we going
Yeah.
to be printing hair? I mean, with
But
3D, I mean,
it's happening.
it's crazy, but I think
There's
we could do it.
It's actually, there's a lady in Columbia University that I had heard a lecture last year that's working on some of those things. So I mean, that is one of those things. That gene splicing and hair cloning are all
Mm.
things that, if it comes around, we'll have buckets of hair. I don't care. I can transplant a 20-year-old. You know, that would be
I'm,
ideal.
I'm,
But
I'm signing up because I want that Fabio look for my 60th birthday. Okay.
listen, Greg, we're going to get a hairline so low with a big temporal point for you. All right, we'll get you ready for 60.
I won't. I won't
It'll be
need
a while from now.
sunglasses. I'll just kind of fold it over.
There we go.
So I think that's been about a half an hour. What do you anything you want to add? And again, I really appreciate you joining me. For everyone watching, I mean, you guys
Yeah.
really this is really a treat because Dr. Lam, truly, I know a little bit about hair restoration. Sam, you're like the guy. I mean, this is really truly one of the leaders, not only within the U.S. but also internationally. So, what would you like to kind of leave anyway saying?
I think the biggest thing is there's a difference between sales and education, and of course this thing is marketing too. We're doing, but I turn away 80% of my patients for that come for consult for surgery because they're just not safe. So safety, find a surgeon who's going to do safe work for you. That you're not meeting a salesperson, you're meeting with the doctor. That's passionate about what he's doing. That can explain to you the risk and talk about ancillary therapies, talk about design, show the before and afters. Really, those are all so important, and I say, when you look at your physician, if he has no passion in his or her eyes, then he or she is not going to do great work for you. And great work is all
Totally agree.
predicated upon a passion for great work and safe work.
Right. No, I totally agree. Well, Dr. Sam Lam, world renowned and proud to call you my friend. Thanks for joining me
Thank you,
today,
Greg.
and thank you guys all for joining in as well too. Stay tuned. In the next week or so, we'll have our next Instagram live session. Send in your ideas for questions to Dr. Buford at beautybybuford.com. That's Dr. Buford at beautybybuford.com. And until then, stay healthy, stay educated, and join us for more fun. Take care, you guys.
Thank you.